Good evening, everyone, and I appreciate you all coming to the Durham County Public Library, the main auditorium. My name is David Bowser. I represent the Sheriff's Office here in Durham County. The reason why we're here tonight, and Sheriff Birkhead will go into a lot more detail, is that this is the first of a series of speaking tours that the Sheriff's going to have throughout Durham County. We really appreciate the main library hosting us this evening. Before we start, I'm going to recognize some community partners that are here. Over on the table, you'll see a lot of literature that will be discussed tonight, and that was provided by our friends at the Durham Crisis Response Center. I met Sherelle Thomas earlier. She's the Community Education Coordinator. Really appreciate you coming. Also, the Duke University Health System, the Behavioral Health. We toured the new clinic up there on Roxborough Street less than a year ago. We appreciate them coming. And also there's some literature from the Durham Recovery Response Center. So again, I really appreciate you guys coming. This is going to be a dialogue here, but we do have a moderator, and that's none other than my friend, the Sheriff of Durham County, Clarence Birkhead.
Thank you, David. Good afternoon, everyone, or good early evening. And as David said, I'm Sheriff Clarence Birkhead here at Durham County Sheriff's Office, and a huge thank you to the Durham County Library and this fantastic space. And if you have not had a chance to tour the entire facility, I encourage you to do so. David and I came over a couple of weeks ago and we took the tour, and it is absolutely fantastic. Put on your walking shoes because it's a massive structure with so much to offer. Right over here, once we're done, I would encourage you to take a look at this kid space. It's a teen space. Just fantastic, interactive computer station set up, and they're actually over there playing games right now. So it's a great building. It's your library. I encourage you to tour it and take advantage of it. And thank you to Tammy for allowing us to kick off our speaking series. This is something we've been wanting to do, and finally, with COVID being a little bit in our rearview mirror, we're able to kick this off and start these conversations all across Durham County. We're going to use various library locations, so you'll hear more about that in the coming future, and we'll post it on all of our social media platforms, again on TV and radio. And there'll be different topics that we will cover. Tonight is mental health, because as we all know, May is Mental Health Month. And so tonight we're going to have a conversation, a free-flowing conversation. It's interactive, so I want all of you to feel free to engage in this conversation about mental health that is so prevalent in our society today. And I've got some folks that I'm going to introduce because they are experts in this arena, and we certainly value their partnership and input. I'll start with Mr. Laylon Williams, Durham County City Crisis Team Training Coordinator and Criminal Justice Specialist with Alliance Health. Laylon brings more than 15 years of experience in mental health, and I'll let him explain a little bit more about what he does in just a moment. And then I have my very own Sergeant Antoinette Page, a 17-year veteran with the Durham County Sheriff's Office. She works in our detention center and has been there since 2003, and she works in the detention office as a supervisor. Sergeant Page is here with us tonight because her current role is our mental health supervisor at the detention facility. And you all may have heard this name before. He's not in the room yet, but Elijah Bazemore recently retired, a major with the Sheriff's Office, very instrumental in getting our mental health pod and our MAT medication-assisted treatment program up and running. Hopefully he'll join us a bit later. Let me pause for a second, because just before I left my office, the news flash, and you all may have heard it, about Texas. And I don't know if it was mental health involved, but there has to be some connection there when a young person, they've identified the gunman as an 18-year-old, that's all we know. And unfortunately we have, is 15, David? 15 dead, 14 students and 1 teacher. So I'd just like to take a moment to pause in reverence of the incident that is happening. And this is the 3rd mass shooting in less than a month. Yeah, and so we're in a crisis. We're in a crisis with these mass shootings. And as the sheriff, I take these situations very seriously, and we get threats here in Durham, and we try to do all we can to prevent them. So let's just take a moment of silence. Thank you. Tonight we have some 363 individuals who are residing with us at the Durham County Detention Facility. And I can tell you that about 65% of those have some form of a cognitive disorder or mental illness. As I mentioned a moment ago, we have a mental health pod in our facility for male and female, and we really strive every day to give them the services and the attention that they need. We have a great staff at the detention center. Some of them are here tonight. I'll introduce them momentarily, but we also have a great partnership with the Alliance, as I've already mentioned, Criminal Justice Resource Center, and her folks who come in and out of the facility to make sure that those who are in need of services can get those services. Our goal is always to make people whole and have them better prepared to deal with society when they go back home, when they're released, and with the ultimate goal of them not returning to the facility. So we really try to work on the wraparound services when they're released from the detention center, connect them with the resources that we have there. So we will, as I said, this is interactive, so I want you all to feel free to ask questions. And I'm going to ask Mr. Laylon Williams if he would come up and tell us a little bit about what he does, and then we'll go to Sergeant Page, and then we'll open it up for questions as we move through this.
All right, thank you, Sheriff Birkhead. So you know they say that you're not supposed to correct your elders, right? So I've already, me and Sergeant Page have already had this conversation over and over and over again. So I'm gonna start it off by saying my name is Laylon Williams. All right, just want to let y'all know that. All right, just in case you heard it, you know who I am. So just a little bit about me. I'm really a free-spirited type person. I got involved in mental health back in 2006. When I first got involved in mental health, I was working out in the community. And when I say I was working out in the community, I mean I was doing face-to-face work with individuals that have mental health challenges, not only adults, but also children. And it gave me a whole different viewpoint on mental health. And I just want you all to know I didn't write anything down because I'm more of a, like I said, a free spirit person. So we're gonna roll with it as it comes out, all right? You know, he said this is gonna be a discussion. That's exactly what I wanted to be, a discussion. All right, so I got started in mental health. And the interesting part about it is I really want this to be more of an awareness thing. And the reason I say that is, of course, like Sheriff Birkhead said, May is Mental Health Awareness Month. But there's an elephant in the room when it comes down to our community, because people don't want to acknowledge that mental health is real, that mental illness is real. Especially in the Black community, we don't want to acknowledge that mental illness is real. When I tell you I've worked with individuals who and seen things that the average person have not seen. You know, people who see things that are not there, people who hear things that are not there, things that happen and you're wondering what is going on with this person right now. You know, and what I actually was interesting is I had a conversation yesterday with a young man who was going through some things. You know, he's divorced, in a new relationship. This new relationship, the young lady said some things during a heated argument that he shared with her in confidentiality, and she called him crazy. Her calling him that actually triggered him because of something that he went through in his previous relationship. So I'm gonna say all that, but I'm gonna say things, and I'm also gonna share some personal things with you all. Like I said, hopefully this creates a dialogue. I have, when we talk about crisis intervention team, so I'm wearing two hats right now. I'm wearing Alliance Health hat, but I'm also wearing CIT Crisis Intervention Team hat. That's why I have my CIT shirt on. Because CIT is near and dear to my heart. Alliance Health is actually a partner within the CIT partnership. And the reason I'm saying partnership, because that's what CIT is all about, Crisis Intervention Team. The Sheriff's Office is actually one of our biggest partners within CIT. But also I have a couple of my partners here who are actually my CIT partners. So if I could get you all to stand and actually just introduce yourselves to the community, I would appreciate it.
Hello, everybody. I'm Laylon Allen. I'm the site director for the Durham Recovery Response Center.
And my name is Audrey Cherry. I also work at Durham Recovery Response Center, and I'm the shift supervisor there.
I know I feel like I'm on a talk show right now.
Hello, I'm Renee Shaw. I am the mental health coordinator for the Criminal Justice Resource Center, and I'm also the chairperson for the Stepping Up Initiative Committee.
I told y'all this is going to be unorthodox.
And just before Sergeant Page comes up, this is great, by the way. Please, thank you all for being here. There is no script. I've got notes, so since I'm a little bit senior, and Mr. Williams, I've got notes. But before we go to Sergeant Page, tell them just a little bit more about what CIT is. Okay, you gonna do that? Okay, and when he said Durham Sheriff's Office is one of the biggest partners, you'll as we circle back to that, you'll understand why. Great. Sergeant Page.
Well, I am Sergeant Antoinette Page, as Sheriff said earlier. I've been with the department almost 19 years of my life. I am a CIT partner and on the team, and I am very thankful for that.
All right, so I'm gonna hold it back here a little bit. So when we say CIT, or we say Crisis Intervention Team, what we basically is talking about, like I said, a partnership. CIT started back in Memphis, Tennessee. What happened was in 1987, there was an incident that happened within the community where a young man that had a mental illness was going into crisis. And law enforcement responded to the scene, but what ended up happening was a fatality ended up happening from this situation. So what ended up happening was the community was outraged, that this young man that had a mental illness was calling to get help and ended up dying from that situation. So they was like, nothing else like this could happen again. They went outraged. They was like, is there a training program that we can get our law enforcement partners involved in? And at that time, it wasn't anything. So this gentleman who was a lieutenant at that time by the name of Sam Cochran was charged with the task of coming up with a training that actually taught law enforcement officers about mental health disorders, substance use disorders, developmental disabilities, and how to verbally de-escalate situations if they come in contact with individuals that are experiencing some of those type of things. So that's kind of how CIT came about. And now CIT is over 30-something years old. It's an international program, and now it's not only for law enforcement, it's also for all first responders. And when I say all first responders, I'm talking about sheriff deputy, police department, EMS, detention officers, telecommunicators, all of these different departments that have these within these different agencies actually come and attend CIT training. And what I've seen from, because it's a week-long training, it's a 40-hour training, but it's not just in the training room type of training. It's a training where the community is actually involved within it. Whereas we have individuals who live with mental health disorders to actually come in and talk to the first responders, to share with them their stories, to share with them what they've lived through, to share with them what they've gone through. And then as a result of it, we also take them out in the community and show them where some of the resources is at, where we would rather have them to take these people to get help and linked to treatment versus getting involved in the criminal justice system. Because that's what CIT was created for. It was created as a jail diversion tool to divert people away from the criminal justice system who didn't need to be in the criminal justice system. Because the research shows that if someone has a mental health disorder, they're in jail or incarcerated way longer than someone who doesn't have a mental health disorder. So that's why this whole fight is to try to keep individuals that have a mental health disorder that don't need to be there, not in that particular system. So that's kind of how CIT started up. CIT started here in Durham in 2007. So we've been doing this for a while now here in Durham, and as the years go on, we've constantly progressed. We've constantly seen different ways to handle different things, and to date, we actually have 1,177 first responders who actually have gone through our Durham CIT training and completed it, which is one of the reasons I'm thankful for Durham, because we really are resource rich here in Durham. You know, and the thing about it is if all of us can just work together and collaborate, you know, things will be a whole lot, you know, better. Sir Birkhead, I'll stop now.
No, that's great. Thank you for that. CIT has really saved lives. And we see these situations in law enforcement where officers will respond to a scene and the situation turns out to be very, very tragic. Sometimes that's unavoidable. Let's just put that out there. That is sometimes completely unavoidable. But if we can get those officers trained in CIT and those deputies trained in CIT, that risk goes way down. I'm very proud of the fact that we have almost 70% of the Durham County Sheriff's Office deputies trained. That includes our SROs. You hear a lot of talk about SROs in school and perpetuating the school to prison pipeline. Not in Durham. Our SROs are CIT trained. They're trained to talk with our young people and develop those relationships. We utilize the referral program and deferred prosecution. We work close with juvenile justice because we know that our kids are dealing with some trauma at home. We know that they bring that to school. So having this partnership and our resources here in Durham and having the SROs have access to that just makes a tremendous difference. I'll tell you a quick story. During the pandemic, which we all have dealt with now for over 2.5 years, there was a student in one of our local schools. They couldn't get in touch with the student. The student wasn't logging on to be in the virtual classroom. So they called the SRO who's assigned to that school and asked if they would reach out to the student. And the SRO did that and was able to make contact with the student and have a great conversation. As they dug deeper, the student was dealing with some very serious issues, borderline suicidal, depressed, and needed some help. The SRO was able to make that connection and get the student the help that they need. And that's a success story because of that relationship and then the training, of course, that the SRO had to be able to have that level of conversation with our students. So I applaud that training, and Mr. Williams knows I'm a big supporter. So Sergeant Page, tell us a little bit about mental health and what we do inside the detention center. And as soon as she's done, you all formulate your questions because we'll open it up for a few questions at that point. Sergeant Page.
Good early afternoon. So to speak about the mental health team in the jail, I would have to first call them absolutely awesome. I am proud to work with them on a day-to-day basis. In our facility, we have a doctor, a supervisor, we have 8 clinicians, and 1 case manager. She said that we have 65% of the people in the jail suffer from a mental health diagnosis. It's more like 80%. That's not even including the ones that don't take medication. So on a day-to-day basis, we check in with the folks with the diagnosis, make sure they're taking their meds. We discuss their issues with them because in the facility we don't do therapy and counseling. A lot of our detainees with a mental health diagnosis, they come in and unfortunately they're released very quickly out of the facility. So we have one clinician and one case manager that actually do our discharge planning. So with that, they will make sure that that person has their medication ready for them when they leave. They will also set up appointments for care, and also they make sure they have housing. So we do a lot for our folks. We are very tired at the end of the day. How many of y'all work in the mental health field? Can't make it up, can you? So, yes, we're very busy down at the Durham County Detention Facility, but it does our heart good to know that everybody that we help, even when they come back, they always say thank you because we put 110% into what we do. We have some of our people, we call them our people because they are people, that return over and over and over and over again, and sometimes you get a little overwhelmed, like we keep helping them, but guess what? We have servant hearts, and to do this work, you have to have a servant's heart. And so we continue to help until one day, maybe they're gonna grasp hold and be able to have the best life. And I tell them all the time, you deserve a good life. You deserve a good life. So that's what we do with the mental health teams.
Talk a little bit more, Sergeant Page, about the medication and how we connect them with resources once they are released. Because she said something very important. They don't stay with us very long, which on one hand is a good thing. But on the other hand, they may need a little more intensive treatment. So medication and connecting them with resources.
So medication, some persons in incarceration already are connected to an ACT team, they already are maybe connected with mental health court, and they already have a set of medications that they take in the community. So we will continue that same medication in the facility. Some people come in, they're off their meds. Our mental health personnel can go into Duke and find out what they've been taking. Our doctor will see that person, talk with them, see what meds works best for them, and we'll get them back on their medication. Once they're released from the detention facility, you know, the beautiful girlies over here, that's the hot spot to pick up your medication. They get a supply, and they also have an appointment to meet with a physician and to try to make sure that person keeps up their medical care, stays on their meds, and all that.
Yeah.
Sure, absolutely. I know Sergeant Page throw the acronym out there that we use in the mental health world, so if someone here doesn't understand the acronym, when she said ACT team, what an ACT team stands for is Assertive Community Treatment Team. And what we call in the mental health world, we call that a hospital without walls. So basically it's a team of individuals that actually serve some of our people that have some, what we call severe and persistent mental illness. That's individuals who really have some severe mental health stuff going on with them. So an ACT team actually serve as their first responder. They actually have somebody that almost come out to see them almost every day to make sure that they stay as stabilized as possible so that way they can, you know, function within the community and so forth and so on. I just wanted to throw that out there for those who may not understand what she meant when she said ACT team.
Oh, that's great. Thank you for that clarification. Sergeant Page, before I let you go, if these individuals did not receive these services at the Durham County Detention Center, how would they get these services?
If they didn't receive them in the detention facility?
Well, here, let me have a qualifier.
Okay.
Do we have individuals who come to the detention center just to receive their services?
Absolutely. Durham County Detention Facility is not a jail. It's a mental health institution. It's a hospital. It's come home so we can get you healthy. It's a lot of things. A lot of our people know if they're not in a good place, unfortunately they'll commit some crime like try to bust the windows out to come in because they know we're gonna take care of them. They know Paige is. They know I'm gonna make sure they eat, they're gonna get their meds, and they're gonna get some special treatment. I ain't gonna tell you I give them $100 because I'll probably get in trouble. The chain of command is here, but yes, they know Paige is gonna take care of them. Absolutely, if they get wounds, if they get into a bad fight, they will. They will come right on in the house. I've told them in the lobby, come on in the house. Because that's where they come to get well. A lot of people's mindset is that the detention facility is a horrible place, but it's not. A lot of times it's a place of refuge for people. It's a place to rest, and it's a place to get back healthy. And they'll leave and say thank you. Because at Durham County Detention Facility, we care about our folks. We care about our people.
Thank you, Sergeant Page. I didn't mean to put her on the spot, but I wanted to illustrate a point that some of you may have heard me say over the years that we do run the largest mental health facility, hospital in the county. I am very proud of the work that we do, but that's a very sad statement. As many resources as you've heard us talk about these past few minutes that we have in Durham, but for individuals have to commit a crime or know that they're going to get good care when they come to the Durham County Jail, to me is a sad statement. And so as a community, I'm hoping that we can continue to build these relationships and have these conversations so that we can direct these individuals who are in crisis or on the verge of being in crisis, not to commit a crime, but get those services while they're not incarcerated. But at the end of the day, as Sergeant Page has said, we're going to help them. We're going to do the best that we possibly can. And when they leave, we hope that they are in better shape. So I'm going to open it up to questions, but I also want to acknowledge, as Sergeant Page mentioned, I have some of my command team here from the detention center. I want to acknowledge Major Spencer, Major Barnes, Captain McKinney, and down a little bit lower we have Major Cody on the law enforcement side. These individuals are critical. They work as a team. I'm not going to tell you what each of them do, but they all oversee special sections of the detention center. We offer over 26, 27 programs in our facility. We just don't lock you up. We want to make you better. And that's everything from GED to diploma to counseling and medication-assisted treatment. We do it all. We have the first medication-assisted treatment program in the state of North Carolina in our jail. We're very proud of it. MAT is a way to address those who are dealing with opioid use disorder, and we do it really well here in Durham. We're about to expand that. So you'll hear more about that a little bit later. So, questions?
Sheriff, I'm good, I think.
John Tarantino, Hyde Park Avenue. Going back to your CIT and partnerships, and I just want to make sure that I didn't miss something in the breadth of the way the tentacles of your partnership work. I wanted to ask you, do the medical units of the military, in particular, say the North Carolina National Guard, do they have something similar? Are they with you, or are they something similar that you know of, or are they potentially looking at you as a future partner? Do you know anything about with the Guard?
Not the National Guard,
Okay.
per se, but we do have a partnership with the VA.
Oh, okay.
Yeah, we have a partnership with VA. They're one of our CIT partners. We actually have individuals that's within their police department that comes and attends our CIT training, but not necessarily National Guard.
I got you.
Thank you, John. Yes, all the way in the back. Run, Dave.
Good.
We don't have to come.
You sure?
Yes. I wanted to say welcome. I'm Stephanie Fennell, Deputy Director for Durham County Library, so I appreciate you hosting us
Thank you,
here tonight. And my question is,
No, that's a great question, and I'm gonna attempt to answer, and I'll answer it this way, just based on the circles I run in from law enforcement and the journals that I read. The short answer is yes. We're seeing more of it, and you all help me out here. And please take the mic and explain, but the short answer is yes, and we know that during the pandemic, we saw an increase or a spike in mental health disorder and people battling with mental health. But as Mr. Williams mentioned earlier, there's a stigma around it in the minority community. So I think the numbers could be even higher if we had more reporting. You wanna add anything?
As far as numbers go, I don't have numbers, but we have percentages. And of course, NAMI, they really keeps up. NAMI stands for National Alliance on Mental Illness. And they throw the statistics out there that 1 in 4 individuals possibly have a mental health disorder. So, you know, it's almost like if we would look in this room right now and do the whole duck goose thing, an individual particularly can have a diagnosable mental health disorder. Because individuals have mental health challenges, but it's only when it becomes to a certain point where it's a disruptor in your life that it can be considered a disorder. So it has to have certain criteria before it can become a disorder. Did you all want to speak more on this?
Yeah, notice he said diagnosable, because some people say I'm crazy for wanting to run for sheriff again, which, and I use that term in jest, so I don't want to take offense. Introduce yourself.
Yeah. Hi everybody, I'm Joanna Tricoli. I'm the Assistant Vice President for Duke Behavioral Health for our health system. So I can speak to Duke's increase in numbers, at least. I'm sorry, I don't know how close this needs to get. So over the last 2 years, we've actually seen a 40% increase in referrals within our health system for services. That does not include people who are self-calling into our access centers seeking care. So what does 40% relate to in numbers? This is for adult only. So we're getting about 18,000 referrals annually. We can't handle that number at Duke, although we are trying every bit of what we can. But that's just for our adult population. I don't actually oversee our child services, but I can speak a little bit to it. We've also seen an increase there, about 30% increase in children. What we are seeing, at least in the hospitals, we've actually had an increase in patients coming who are actually having, I don't want to say successful attempts, but actually attempting suicide or overdoses, which is up from what we used to see. We used to see maybe three kids coming in with suicide attempts or overdoses over about a 3-month period. Now we're up to about 25 in a 3-month period, and that's high for our children. Again, this is all throughout COVID. Not to say that COVID is a direct impact of it, but it is certainly a large impact of it. We have historically seen year over year an increase in patients seeking mental health services, but certainly over the last 2 years. In our EDs, we've also have seen a pretty significant increase. And just to give perspective, I know we mentioned earlier about our new facility. We planned for 16 behavioral health beds in our ED at Duke Regional, thinking that we would have an average daily census of 14 patients. We're actually averaging about 25 patients a day coming, and that's just at our one hospital. So although we built a new facility to accommodate an increase, we are surpassing what we thought we were. And a lot of that is in the community. Resources are scarce for outpatient treatment. So we have really great crisis response, and Alliance is one of actually our best partners from a service perspective, but we still have a lot to do in the community with building resources that are needed for our community through Durham, and then also widespread for that. So I think a lot of that is, we see that trickle down into crisis response, our EDs, because that outpatient or that initial care when someone needs treatment on the early onset of a symptom, it's hard. And I think we're all doing to respond to it, but I think especially as the stigma decreases, or as we try to decrease the stigma, we need to have the resources to back that up for patients who are seeking care. So, sorry, that was a very long-winded explanation.
I'm glad we invited her. I don't want you to get lost on those numbers. 40% adult, that's astonishing, and 30% juvenile or young adult. So yes, there's an issue here. And then the other thing that really stands out, we do a great job in crisis response. We really don't do a good job in treatment and offering services to those who need treatment and are not in crisis. And then the final point I want to make here is, and I'm going to ask this question and open it up, how do we destigmatize mental health? And we all know someone in our family who just refuses to acknowledge it. So, and that question may be for later, but how do we break this stigma and get people the treatment and the help they need? Yes, ma'am, I saw your hand.
Oh, well, the point to that is that we have to educate them, and it's a long process, and we have to see what other people will do. Other people have to see what you're doing that's appropriate to avoid making people feel that they're stigmatized or making them feel bad because they do have problems. Because what you really find out now, a lot of people have problems. They just don't have the diagnosis for it. And a lot of times it might be because they're not incarcerated or whatever. And the other question I had was, are there any outreach programs where you go into the community itself and talk with these people that may be homeless or whatever?
Yeah, there are several. I'll open it up to, or I want to take some of that. But the answer, again, the short answer is yes. And there are a number
Of our community and private partners who do outreach work. Maybe we can get more of them to come to the next conversation. As David mentioned earlier, we have a lot of resources in Durham. We just have a difficult time connecting those resources to the people who really need them. But yes, there are those.
Hi, I'm Audrey Cherry. I work at Durham Recovery Response Center. And we actually work with, we're located right next door to Duke Regional Hospital. So we do a lot with Big Duke Regional, as well as the detention center. We try to kind of take people that might need more focus on their mental health and substance abuse issues. And what we do is we, as a crisis facility, we help stabilize people. So we bring them in for mental health or substance abuse, and we try to provide that stabilization and then also connect them to the next step, transition them to whether it be outpatient services or, you know, for some people they may need a higher level of care. We serve people of all different, you know, people of all different socioeconomic statuses and whatnot. So whether it's somebody that is in a mental health crisis and they may be homeless, we're going to try to connect them to services in the community, not just send them to a shelter, but really connect them to housing or whatever it is in the community that may be supportive to what they're going through.
Thank you.
Okay. Yeah, so we serve as a jail diversion and an ED diversion program. So we're here to assist the hospitals and also assist the jails. So just as Sheriff Page was saying, we have people that come back regularly, and we call them ours as well, friendly faces. So they may not get it the first time, but we're always there. Our door is always open. We have a no wrong door policy. So whenever anybody comes, they, you know, it's no set limit, you know, on the number of times they can come. So they can come today, and if they're not ready and say I'm ready to leave, and then next week try it again, our door is open. And so we're always there for them.
You have, Mr. Williams, you have anything to add about outreach? Oh, yeah. In the community?
So as far as outreach go, there are different, I guess, agencies that come to mind when I think about outreach. I know that, I don't know if you all still have it or not, they used to have a peer navigator Okay, so it was a peer navigator and a peer bridger program that they had. And what that entailed was, it was someone who had lived experience. Like when you hear someone that say peer support specialist, what that is someone who have lived experience who's going back out to try to grab the hand of somebody else to help them along their journey where they may be in crisis, where that person who have lived experience have already been there and done that. You know how they say, you know, I've been there and done that and bought the t-shirt, wore the t-shirt and all of that. Individuals actually are a lot more apt to get help when they have somebody who's been there and done that to help them along the way, to hold their hand and kind of walk that path with them. What we found, because with Alliance Health, we're the MCO. When I say MCO, it stands for Managed Care Organization. So we're the agency that's over the mental health, substance use, and developmental disability providers that provide the services within Durham. We had a different provider that was running our crisis center at one time, and when they had more of a hospital type atmosphere, and we found that individuals didn't want to go there because of that type of atmosphere. But now, because we brought in a different provider, they have what we call a living room model type approach, where they actually have remodeled the facility, and it's actually it's a lot more peer ran now. So when individuals show up there in crisis, they're met by somebody who have lived experience that's a lot more apt to connect with them, and they won't be so apt to walk away and say, I don't want this help. So it's a lot of different things that's out there. We're now trying to put together a lot of the resources behind a lot of this, so that way we can get it out to the community. I was just sharing this morning on my Durham CIT Leadership Committee meeting that I've been in communications with another lady from another MCO, and what we're trying to do is do a community crisis training. And what the community crisis training entails is basically educating the community on what crisis services is within your community. And if you have someone that goes into crisis, how do you respond to it? If you have somebody who may be having suicidal thoughts, how do you respond to it? What really triggered me to get even more in depth with this was I was in a meeting probably about a week or two ago, and one of our county commissioners shared at the meeting that I have a friend, and the friend called me saying that she wanted to kill herself. And I didn't know what to do. Think about it. As a community, if someone calls you with that kind of conversation, what do you do? So I say, you know what, this is something that we do need to start thinking on, to educate the community on what to do if they have a crisis situation like this to happen. Where are the resources that they can reach out to if something like this happens? You know, we have in the mental health world something that we call person-centered planning. And what it is you putting a plan together for this person if they were to go into crisis, and working on different goals that they have. But the plan is worthless if the person that is supposed to serve is not involved in it. Same thing, you know, I feel like all these different systems is going on, but if we're not educating the community, the people who actually benefit from all of this on what we're doing, it's kind of worthless.
Chair Birkhead, can I just add something to that? So I appreciate what you're saying, I appreciate your reflection, because I think that language and education is the biggest piece to me in reducing stigma, because if you're experiencing a medical emergency, you know where to go. You know to go to an emergency department, you know to go to an urgent care, you know to go to your primary care doctor. If you're experiencing a behavioral health emergency, which can impact your normal thought process, right? If you don't know where to go. It's not as ingrained in our common language to know where to go in those emergencies. On top of that, if you're, and I'll share my personal experience during COVID, I had to go to therapy, right? I work in mental health. I can't go to Duke, right? I don't want my own providers. I don't want to see my own providers, right? But for me to even navigate the system outside of Duke with insurance and all of that, it becomes complicated. And if you don't know the language to speak and how to navigate, it's so easy to say, I'm not going to go for care. I'm not going to seek care. And then you end up in our emergency department, right? So I think it starts with the education of the language and the resources to help guide where you need to go, truthfully. And opportunities like this to have this conversation, because then you can go tell a friend, hey, this is what I heard, and then it starts to get that out, in addition to the formal work that people are doing. But it really is about the common language and understanding what's the equivalent for behavioral health responses as it is for medical responses. Because we know how to respond to a medical, where we go for medical treatment. We don't always know where to go. Once you get me talking.
No, that's great. I see a couple of hands. I saw Regina and then the young lady here. Regina?
And I know Regina, so I can call her by her.